What's up, guys? Dr. Mo here, digital nomad physician at digitalnomadphysician.com. March 8, 2024. Time for taxes, time to plan out the year. Yeah, time for a bunch of new and exciting things. So, all right, today let's talk about the patient visit. This is for physicians who are maybe new out of residency, and also for seasoned physicians who have burnt out and who maybe are now finally in that place where they're like, I think I could go back and see some patients, but I certainly can't do it the way I did it before. The old model burnt me out, and I'm just not going to do it like that. So what are the options, right? You certainly can go into private practice. In fact, I have a great course on starting your own virtual medical practice, your own online clinic in 8 weeks. So you can check that out at nomadphysician.com if that's what you're interested in. You can go work for a private practice, something much smaller, so it's not as crazy. And of course, you can go back into the traditional mainstream, kind of busy, large medical group system. So how do you do it? No matter what, you're going to have to set new boundaries, and you're going to have to reimagine the way you see patients. One of my good friends told me that it's easier for male doctors to see patients than female doctors because men have an easier time setting boundaries, and patients don't dump as much emotional baggage on you. And that could be the case. It certainly seems like for me, I have an easier time setting those patient boundaries, which protects me in a lot of ways, but also protects the patient. So we're going to dive into that. And so to break this down, we're going to talk about 3 things. The first one is going to be timing, how you spend your time in everything from preparing for the visit to during the visit and time after the visit. The second thing is going to be the boundaries that you set between yourself and the patient, between you and the administration, between you and your medical director, whatever it is that you end up having to deal with. The final one is going to be expectations. So this is different than boundaries, but these are some of the expectations that we think somebody has placed on us, or the expectations that we have of ourselves. So diving in, probably the first thing with timing that comes to mind, well, I guess the overarching thing that I want to talk about is that you don't have to stress over the patient visit. You don't have to make it complicated, and you don't have to do it the old way. You don't have to do it like other physicians are doing it, even if you work for a large medical group like Kaiser Permanente. Yes, there's going to be a lot of expectations on you, but you can still do it your way and get away with it. The old way was we step in the room, we try to be the best physicians we can, we try to get a lot of information from the patient, and no matter what it takes, we're going to stay in that room until we get that information, until we tuck the patient away, finish them up, package them up nicely, and then go on to the next patient. That is not sustainable. To understand the overarching theme is the current insurance model, this model that exists, which is not the only model that patients have an option for, is based around short visits with the patient and doctor together, coming up with a plan, and then executing that plan over a long period of time. Everything's broken up into little segments. I don't know if this is a good thing or a bad thing, but this is our current healthcare model. For me as a patient, I like to be able to go see my doctor and have one very long, comprehensive visit. And some of you specialists are going to be quite frustrated to understand that once you're in actual practice, or once you return back to practice after burnout, you're really only going to get about 30 minutes for even a very extensive initial visit. You're not going to get 1-hour appointments. You're not going to get 45-minute appointments. Now, some of you might say, of course, I have those. I have that option to me right now. I get 1 hour with my patients. That's not common. And if it is happening in your practice, that actually might be the handcuffs that are keeping you at that job. Even if you don't like that job, you might tell yourself, well, I'm never going to find another opportunity where I can spend this much time with a patient. And that's going to keep you hostage, because that's not the only way to do it. Again, we're not going to talk about whether it's good for patient care, bad for patient care. I expressed my own personal preference, which is I want to have a long session with my doctor in the beginning. I want to have multiple longer sessions afterwards, and then I want to be able to asynchronously continue communicating with my doctor for however long it takes for me to feel tucked in. So when it comes to timing is, to me, timing means that you're going to set a certain expectation for yourself and the patient. Usually, the best thing that you can do is create this boundary of time where you can set a timer for yourself. You can let the patient know ahead of time when you come in and say, hey, Ms. Smith, this is going to be our first session together. I hope to get to know you and understand what is going on. And I'm a specialist. I'm a allergist. I'm a rheumatologist. I'm a gastroenterologist. And it's going to take us a few sessions probably to figure out what is going on. But I want to spend this next 30 minutes together that we have to tease some of the things out. So being mindful of this 30 minutes, we can certainly use it any way that you like, but I certainly have some questions that I'd like to get answered. There are some tests that I want to order, and there's some physical exam things that I really need to do to figure it out. Now, of course, the patient might hear all of that and still go on and complain about the front desk, and then complain about their doctor, and then complain about the medical system, and then complain about the insurance. This is the patient venting. This is the patient actually building a rapport with you. We sometimes can see that as doctors as like, fucking asshole, like, dude, like, you know, you're wasting my time, you're wasting your time. I'm trying to help you, and you're sitting here bitching about the front desk because you didn't like her. And that's the initial way that I guess maybe we've learned to think about that. But another way to think about it is the patient now understands that this is the amount of time that they have with you, and they really need to get that off their chest. And honestly, people who have problems with temper management, anger control, all of that stuff, that's actually really cathartic for them to be able to say that and then be in a safe space or feel like, oh shit, this doctor actually is going to listen to me, especially people with history of bad things that have happened to them. When they can say all of that and not feel judged, they all of a sudden drop their guard. I've seen that happen. You've seen it happen. Sometimes when you just let the patient vent, because you're so tired, you're so burnt out, you're like, fuck it, man, say whatever you want. Yeah, fuck that front desk. I hate that motherfucker or whatever. And you're just like commiserating with them. And all of a sudden you connect. And all of a sudden everything goes really smoothly. So set the boundary in the beginning of time. How much time are we going to have together? And these are the things that I want to get done. Just because it doesn't happen, 20 minutes into the visit, the patient is still complaining about the medical system and the orthopedic surgeon that they saw and this and that person. That's fine. That's okay. You now, into that 20-minute mark, you can say, so I do need to ask you a few questions, and I still need some time for that physical exam. Now, remember, you need to have that structure in your mind where you say, I still need to ask some questions, and I need that physical exam time. So we only have about 10 minutes left. And there's nothing wrong with looking at your clock, especially if you got a large monitor in front of you, or you have a watch or your phone or something like that. And sometimes that's enough for the patient to then redirect, and you can then ask all the questions, your pertinent negatives, pertinent positives, your past medical history, whatever, and then say, okay, so I got to do a physical exam and I got to get some more information. Oh, I see you. I didn't know about this old, management that you had with this other specialist. That's a lot of information right there. I need to get my hands on that. Are you able to request those records? Are you able to talk to my front desk so that we can request those records? We're going to need to address that at the next visit. Now, sometimes as a patient, you might feel really frustrated because you think the doctor didn't do anything for you. And that only happens often when you just leave the patient hanging at the end. Instead of spending a few minutes towards the end, just summarizing, say, hey, look, I got a lot of information from you about you bitching about the front desk also, but I got a lot of information from you about your history and what's been going on in the past, and I'm still getting to know you. I know where to go look for some more information from your old records, and there are some tests that we're going to order, and actually there's this medicine that you're going to try. So this is really good. It's a good starting off point for us. But I need to see you back in 2 weeks. I need to see you back in a month so that I can continue gathering more information. For the next visit, I'd like you to help me gather some of this information and maybe think about some of these symptoms and questions that I asked you, reflect on it. And when we get back together, we're going to review some of this stuff, and I'm going to go dive in deeper, and we're going to talk about this old surgery that you had and this other visit you had in this other country or with this other specialist. When you ended like that, and this took me about a minute to say, I don't think it was excessive. This mental organization, you still kept the patient within the constraints of time of 30 minutes. Now, I'm talking about the specialists. For me, as a family medicine doctor, we're talking about 7 minutes because I still need time to chart. So for me, it's the same thing. I come in and I say, Ms. Smith, we have about 10 minutes together during this appointment until my next visit, or I can say 15 minutes. Usually it's 10 minutes. And I want to gather a lot of information from you. And I really want to talk about your knee pain, which I think what you're here for. But it's also a good time for us to get to know each other. I want to leave some time for you to tell me everything that's going on, for me to ask some questions and do a physical exam, and hopefully some time for me to order some tests, etc. Saying that over and over until you become really accustomed to it can be a great way to come in the room and just for yourself to just like let go of that stress that you might have, that this patient's going to have all these expectations of you and they're going to be upset that you're leaving. If they now say, what, that's it? I mean, I didn't even tell you about my symptoms. I understand, but that 30-minute that we discussed in the beginning was important for me. Or you can say that 30 minutes that we set aside together is an important time frame so that I can get to my next patient on time. And so that the next time that we come together, we can still set those boundaries as we move forward together. If you can deliver that in a good way, great. I can tell you when I've set that boundary in the beginning and the patient's shocked about the 30 minutes towards the end, or, again, for me, it's usually 10 minutes. It's almost always because I didn't express it properly, or it's because they just want to vent. They just want to tell you that they're upset that they only have 10 minutes with you, that they only have 30 minutes with you. Sometimes you can just hear that and you can just say, I know it's really frustrating, but I promise you, we have some really good things. In fact, I'll wrap it up for you just so you get a sense of how much we really accomplished in this visit. And during our next appointment, we're going to have a lot more stuff to talk about. So sometimes the patient just saying that is not them being upset, is just them wanting to vent and express that this is not going according to plan. And that's still okay. It can still be a meaningful patient-doctor relationship. So this is the timing. And now we're going to talk about boundaries, setting boundaries. So if my friend is right and she says that male doctors have an easier time setting boundaries, let's just say that's true. I know that I have certain boundaries that I can set. So I'll break down the common things that happen with me and my patients where my boundaries are transgressed or my boundaries get broken. I never feel good when my boundaries are broken because I feel outside of my comfort zone. Classically, you can imagine a mechanic comes in and all of a sudden you're telling him about this, body dent that your door has, and they're like, "What? No, I can't. No, I'm not going to do that. Like that's a mechanic. That's a body shop issue. I can't deal with that." And they're flustered. They're frustrated because they're like, "I don't know how to deal with that." And it's the same thing if you go to a surgeon and all of a sudden talking about your diabetes. When you come to me and now you're complaining about the system, the healthcare system, you're complaining about the front desk, or you're wanting me to give you this work note that is super weird and structured in a way that you have 8 months off and you want me to fill out this form that I don't do. You need to figure out what is it that you do and what you don't do for a patient. Those boundaries are incredibly important. Do you fill out FMLA forms? Do you think maybe you could bump that down to the primary care doctor? Or if you're the type of primary care doctor that's cost covering, do you think you really need to fill out that FMLA form? Do you need to refill the narcotic? Do you need to do the pain management for the patient? Do you need to talk about their depression and anxiety? Is that really something they're there to see you for, even if they bring it up? Remember, as a doctor, if you don't set boundaries, the patient is going to be like, they're going to talk about everything. They're going to feel really unstructured. In fact, they're going to feel flustered because you're not setting the boundaries. You're not giving them a clear path to walk. You're not giving them borders that they know not to cross, and they're going to get lost. And in the end, you're going to get nowhere. If I'm a rheumatologist and the patient comes to me when they were referred to me for rule out of lupus, in those first 30 minutes, I'm going to gather that information. I'm going to do the physical exam, and I'm going to figure out if this is some sort of seronegative autoimmune disease. And I'm going to order some records from before, and I'm going to order some tests and probably do some imaging and do a physical exam. Now, why am I trying to figure out if this is a chronic pain issue, a depression issue, anxiety issue? That's not for me to figure out right now. I have one mission, and that boundary that I set during this first mission is, one of them is timing. The other one is the patient's not really upset and crying and everything. My boundary is you can definitely cry, and I'm going to hold space for you to cry, but we're going to continue with the visit. And if it feels too uncomfortable to continue with the visit, we can certainly take the next 3 minutes that are left in the appointment to just, for me to hold space for you when you're crying. This can seem a little bit insensitive to some of you who are listening to this. I certainly understand. And again, I'm approaching this with big picture in mind that you are working in a system that is maybe not the way you think medicine should be practiced. If that is the case, you're practicing in the wrong medical system. And the only option is to find a different system or create your own system. And I think that's the main reason I have Digital Nomad Health, my own private practice, because I don't want to practice in that system. I want to practice in that system on occasion to still stay connected to that system, because those are very different patients. Very different types of patients come to me in my practice. And I want to learn some things that I may otherwise not learn, but that's not the kind of system I want to be in. But if you're going to practice in that system is this way. The patient's going to come, and there's not much room for emotional type of stuff. There's not much room for talking about administrative things. You're pretty much just going to have to take care of that condition that they're there for. And you're going to have to be the one who really, really stays focused on that topic. For me, boundaries also involve if the patient wants to yell at me, wants to belittle me, wants to belittle another colleague of mine or my front desk. My boundary is, I'm sorry, I know you seem very upset, but this is not going to be a good conversation if you're going to talk down to me. I really want to address your health. I really care about what is going on here. And if we can move forward amicably, if we can move forward in a positive manner, I'm happy to be here for you. Please let me know if we can discuss this. So I don't really say, do you want to do that? Do you want to, because that's going to instigate them. They're already pissed, right? So then I just immediately, after I say that, I say, look, I really want to find out more about your knee pain. And then there's going to be that really awkward moment, and then they're going to tell me about their knee pain. And then as I keep redirecting them into that, they understand, like, shit, I hit Dr. Mo's boundary. Shit, I hit Dr. Mo's boundary. Okay, let me bounce back in the middle of the road and see if I can get somewhere. We set boundaries for ourselves so we don't leave at the end of the day super frustrated, and we set boundaries so that patients don't get confused and take advantage of us. And their health will suffer in return, right? In the end, the patient's health suffers. At the end of the day, if you feel super fucking drained, or if you have a lot of anxiety going to work the next day, in my opinion, one of the big issues is that the boundaries that we set just weren't good. Either they weren't good, or no matter what boundaries you set, it will not work in that healthcare system. Now, of course, my belief is that in any healthcare system, you can set the right kind of boundaries and create the right kind of timing and set the expectations in a way that it will work. But that's a tall order. I think there are some systems where it's actually quite impossible to prosper. Finally, expectations. There are expectations from the governance of healthcare, from medical boards, from insurers, from attorneys, from administrators. There are expectations from your medical group. There are expectations from your fellow physicians in your office, and there are expectations from the patient. And of all, the most important is the expectation that you have of yourself. When you break that expectation of yourself, you have this high expectation of yourself, and you break it, these micro fractures that you create, you actually start being the harshest critic of yourself. A lot of the expectations that we feel are not really there. No patient is expecting you to solve their problem in the first visit. No patient is expecting you to be God doctor. Even if they're saying that, they might be saying that, but I genuinely don't believe anybody's expecting it. Nobody's expecting you to know. Even if you're the specialist, they expect you to care and ask the right questions and explore and find out and research until you figure it out. The fact that you think the expectation is there for you to know everything, that's self-created. That's you creating that expectation. It doesn't mean you're an asshole, doesn't mean you're a dick, it doesn't mean you're an idiot. It means that you've created that pressure on yourself because you want to perform as this great physician who's going to stand out. I, Dr. Mo, am a mediocre physician. Now, for any malpractice attorney in the future who's going to listen to this and use this against me, of course, I'm going to tell you mediocre means I'm right in the middle. I am in the center. I'm at the median of all the other physicians. I'm not better than other physicians. I'm not worse than any physicians. I have no data to prove that I'm better than another physician. If you're listening to this and you think you're better than other physicians, I don't know what to tell you. You might be. And if you really are better than other physicians, you're probably better off working in a very narrow system, in a very niche healthcare system where you can capture the kind of patients who can help you be really good at what you do, be great at what you do, as opposed to mediocre. The healthcare system does not, in any shape or form, reward or offer any incentives or encourage you to be above and beyond. In fact, they punish you. In fact, they punish you for doing certain things above and beyond. And I will actually say, and I hate to admit this, the system is designed so even if you're in the middle, you're a mediocre physician, you're still giving the patient an incredible amount of service. So that's just my little thing for any future attorneys who want to be a fucking asshole and use this against me. Now, I'll say that certain patients will have very crazy expectations of you. Well, I don't understand. The other doctor refilled my promethazine with codeine. Why can't you? Are you saying that other doctor is an idiot? That's more of a confrontation. That's more the patient just venting. That's the patient. That's a patient problem. That's a them problem, not a you problem. You are saying, "Oh, yeah, I totally understand. That's frustrating. Yeah, unfortunately, I can't refill it. So for every medical condition, there are certain things that are appropriate in my practice. I can't practice like the other physicians that you mentioned. Certainly, in this situation, there is cough medication is warranted. If you're open to some benzonatate or some other medication, I'm happy to prescribe that for you." And then you leave it at that. Now, the patient might continue their rant, their frustration, and you got to be able to give them room. That is one of the skills that you can develop as a physician, to give the room for another person to just be angry, to just be upset. But you don't have to do what they want you to do. You know what I mean? So expectations that come from us, they're worth just checking and writing down. What are the expectations I have of myself to be a great doctor? Literally, I don't have that expectation of myself. My expectation is the training that I had to be the kind of doctor that I am is adequate. Now, I have an expectation of myself to continue reading about the most up-to-date stuff. That's it. That's the expectation that I have of myself. And even then, when I don't meet it, that's still okay. The expectation that the patient have of you could be all sorts of stuff, that you should be the most fancy doctor. You should not have an accent. You should be well-shaven. You should not wear that shirt. All sorts of, my patients are like, "Why are your name Mohammed? Change your name." I've literally had patients tell me that. I understand that. That's their upbringing. That's the way they were thought. They were raised. That's the expectation they have of me. It has nothing to do with what I'm going to do or have to do. I can continue practicing medicine the way I think is fit in this clinical situation and demonstrate to the patient that this is really vital. This, what I'm doing, is really going to help them with their health. And their expectation can be their expectation. That's a them problem. Now, there might be expectations that your medical administration has, that you need to meet HEDIS scores and do this and see 12 patients an hour. My question to you is, what would happen if you saw only 10 patients an hour? What would happen if you actually became late and the last patient left? What would happen? Would you really get fired? I mean, that's maybe something you're thinking, but would you actually get fired if the last patient of the day left, right? I work in the urgent care, and I intentionally, towards the last 2 hours, about 2 hours of work, I slow the fuck down. The administration could come down on me and say, "You're so much slower towards the end of the day. You take so much time with the patients. You document and chart so much more." Well, I also know that my concentration is decreased towards the end of the day. And I know that if I keep seeing faster patients, that exam room, that waiting room, which the nurses are emptying so that the new patients who come see an empty room so they come, is going to keep filling up. So it's shooting myself in the foot, and it's not going to help the patient. If I'm seeing patients at a faster rate that I'm comfortable, I'm hurting the patient. Now, nobody's going to give a shit about that. I know that. No judge, no jury, no malpractice attorney is going to care about that, but you should care about it because you care about your outcomes. That's my expectation of myself, I suppose. So I slow down. And so far, about on average, 1 or 2 patients leave at the end of the day because they've waited 2.5 hours and it's super late. And that's it. That's okay. They leave and nothing's happened. I haven't gotten fired. And I've been doing this for quite a few years now. So my question to you is, if you think there's an expectation of administration, really check that. Really check that. And also, if that expectation is there, what are you willing to lose to not have to surrender to that expectation? That's a good question for you to consider as well. So I hope this is helpful, guys. This is the tough part of practicing medicine for sure. But being able to navigate this, being able to figure this out, I think is really helpful for the patient. Most importantly, it is helpful for us because it can maybe prevent us from getting to a place where we just don't want to fucking practice medicine anymore. And I hope these are great tools. If you have some things that are working really well for you, share it in the comments below. Take care.